Hi, and welcome to the Bolin Animation Studio. My name is Professor Wilfred Duncan Muir, and I'm a seasoned urologist. This is a course about renal tract obstruction. I will adopt a textbook approach and cover the basic physiology and pathophysiology that is relevant to understanding how the kidney responds to the obstructive insult. However, my goal is to keep a clinical orientation to this lecture and show how basic scientific principles can be used to direct clinical management. But first of all, I'd like you to meet my friend and colleague, Dr. Louise Murray.
Hello, Professor, and thanks for inviting me to join you.
Louise is currently doing her fellowship exams and is revising hard. She will be presenting a case history for us, and we will discuss the course material together. My plan is to divide this course into 5 sections. In part 1, I will summarise the common ways in which renal tract obstruction may present and highlight some of the specific clinical problems that may arise. Following this, I will cover the basics of renal physiology. In part 3, I will discuss some more advanced physiological concepts that will be revisited in part 4, the physiology of obstruction. In part 5, we will turn our attention to the practicalities of patient management. It will be a roller coaster of a ride through a huge subject. Each section will build on the previous one, but for revision, the individual sections can be watched in isolation. Let's start with an overview of how renal tract obstruction may present. Renal tract obstruction may be partial or complete. The onset may be acute, or it may present in a chronic, more insidious way. It may involve one side alone, or both kidneys may be obstructed together. Finally, the obstructive pathology may involve the upper tracts alone, or the upper and lower urinary tracts together. Clearly, there are a myriad of pathologies that may block the kidneys in different ways. Similarly, the consequences of such an obstruction will vary widely. Louise, let me illustrate this with some examples. The commonest cause for an acute unilateral upper tract obstruction is renal colic. You will be familiar with the patient who presents with acute loin pain. Now, most stones will pass spontaneously, but situations can arise where a small stone is retained and the patient may become asymptomatic. Such an obstruction may then become chronic. However, there are many other causes of chronic unilateral upper tract obstruction. For example, congenital pelviureteric junction, or PUJ obstructions, are not uncommon. Similarly, any neoplastic or inflammatory pathology can cause extrinsic compression to the renal tract. In each case, a hydronephrosis may develop, and eventually atrophy of the kidney may occur. Of course, pathologies that cause extrinsic compression can just as readily obstruct both sides. Pelvic malignancies are the most common culprits and will include cancers of the bladder, prostate and cervix. However, for chronic bilateral upper tract obstructions, the key difference is that renal failure may also occur. A specific problem to which all obstructed kidneys are more susceptible is infection. A hydronephrosis that becomes infected is called a pyonephrosis, and an obstructed infected system, or obstructed pyelonephritis, is a surgical emergency. The ultrasound guided placement of a nephrostomy tube is the best management option in the acute situation. The commonest cause for an acute bilateral upper and lower tract obstruction is acute retention of urine. This occurs in older men and is usually a consequence of benign prostatic disease. However, I do believe that you have a case to present to us, Louise.
Yes, indeed, Prof. I dealt with such a case earlier this week. It was late afternoon, and an elderly gentleman was brought to the accident and emergency department in acute retention of urine. At first, his case seemed fairly straightforward, but as the night progressed, some unfortunate complications developed.
Yes, Louise, I remember this case well. Please present the relevant points in this man's history.
OK, Prof. Joe Bloggs is a 72-year-old man who had previously had little in the way of lower urinary tract symptoms. However, on Monday morning, he woke to find that he had a little difficulty in passing his urine, along with some urinary discomfort. By Wednesday, his voiding difficulty was getting progressively worse, and he had started to develop some lower abdominal discomfort. On Thursday, although he was still voiding in dribbles, he was aware of a marked distension in his lower abdomen. On Friday, he was feeling febrile, and gradually he became unable to pass any urine at all. On arrival, a diagnosis of acute urinary retention was made, and he was easily catheterised. A 1.5 litre volume of urine was drained, and he was admitted to the urology ward. His past medical history was fairly unremarkable. He was not constipated and had had no previous lower urinary tract surgery. He had taken no additional medication, such as an anticholinergic, that might have helped to precipitate an episode of urinary retention. However, he was taking non-steroidal anti-inflammatories for rheumatoid arthritis and an ACE inhibitor for well-controlled hypertension. But other than that, he really was in reasonably good health. He'd been settled on the ward and seemed to be quite comfortable. However, at midnight, he suddenly had a cardiac arrest. Fortunately, we were able to resuscitate him quite quickly. Transient cardiac arrhythmias did continue through the night, and we did need to correct a marked hypokalemia that had been identified along with some other mild electrolyte disturbances. Eventually his condition stabilised, and I'm pleased to report that he's now doing well on the ward.
Thanks, Louise. That summary illustrates the main theme that we will be exploring further in this programme. But before I tell the viewers what that is, please will you tell us about his urine output prior to his cardiac arrest?
Well, reviewing his fluid charts is really quite interesting. It does seem that he was experiencing a fairly marked urinary diuresis, actually in excess of 200 mils per hour.
Yes, and this is always a worry when we relieve an obstructed urinary tract. It is likely that this man suffered from a complicated post-obstructive diuresis. I will be discussing this in depth, but first we need to make sure that we truly understand the inner workings of the kidney. You see, when the kidney is in distress, she responds in a predictable way. But before we discover what that is, let's make sure that we have a sound understanding of basic renal physiology. Climb on board and let the ride begin. The kidney comprises three anatomically distinct regions: the cortex, which can be divided into outer and inner regions, the medulla, which forms discrete pyramidal zones, and the collecting system. Under high magnification, the cortex can be seen to house thousands of thread-like tubules called nephrons. The nephron is the basic functioning unit of the kidney. The Bowman's capsule is at the head of this filtration unit. The glomerulus is the leash of capillaries within the Bowman's capsule that receives blood from an afferent arteriole. The efferent arteriole takes blood away from the nephron. The vasa recta arises from the efferent arteriole and selectively reabsorbs the filtrate along the nephron. The vasa recta merges with the venous circulation. Each region of the nephron is functionally distinct. The proximal tubule reabsorbs 80% of all the salts and water filtered. Likewise, most amino acids and glucose are handled by this segment of the nephron. The loop of Henle is a very specialised portion of the nephron that descends from the renal cortex into the renal medulla. It uses an active metabolic process to create a localised region of hypertonicity. This facilitates the reabsorption of water by the collecting ducts as they pass through this space. The main function of the collecting ducts is to fine-tune the reabsorption of water. This process is regulated by a hormone produced in the hypothalamus and released from the posterior pituitary gland. This hormone is known as the antidiuretic hormone, or ADH. The more specific term for this hormone is arginine vasopressin, AVP, or simply vasopressin. This is also the region of the nephron that controls the coupled interchange of potassium and hydrogen ions. As such, the collecting ducts are the prime regulatory sites for both potassium and acid-base balance. The distal convoluted tubule continues the reabsorption of salt and water and is important in the handling of certain ions such as calcium. However, the most important function relates to the role it plays in what is referred to as glomerulo-tubular balance. Specialised cells in the distal convoluted tubule, the macula densa cells, communicate with the afferent and efferent glomerular arterioles. The association between these structures is subtle, and collectively they make up what is known as the juxtaglomerular apparatus. On closer inspection, we can see that the component parts of this apparatus, the distal convoluted tubule and the afferent and efferent vessels, are really quite tightly associated. Is this a concept with which you are familiar, Louise?
Yes, Prof. The concept of a discrete juxtaglomerular thing is well described in the textbooks. But please tell me, do you regard the juxtaglomerular apparatus as being an anatomical or a physiological concept?
Well, it's both really. But to understand why this should be, we need to study the ultrastructure of these elements. If you reduce this apparatus to its individual parts, we can start by building from the Bowman's capsule. The outer, or parietal epithelial layer, houses the glomerular tuft of capillaries. An inner, or visceral epithelial layer, specialises to form cells known as podocytes that ensheath the capillaries. This interface forms a three-layered filtration surface. The small glomerular capillaries have a fenestrated endothelium. This endothelium is covered with the basement membrane. This membrane separates the capillary surface from the interdigitating podocytes. The filtrate from the capillaries crosses these three barriers sequentially to enter the Bowman space. From here, the filtrate enters the proximal tubules. The glomerulus is a highly specialised vascular structure. It receives blood from the afferent arteriole at a relatively high pressure, usually about 35 millimeters of mercury. The capillary path is long and provides a huge surface area for the filtration of plasma. However, the resistance in these vessels is very low, so the blood pressure drop in the efferent arteriole is minimal. Changes in afferent or efferent arteriolar resistance will profoundly affect glomerular function. For example, increasing afferent arteriolar resistance will reduce glomerular pressure and filtration will diminish. In contrast, increasing efferent arteriolar resistance will result in a rise in glomerular pressure and the filtration fraction will increase. These events are mediated by a complex interplay of chemical and neurovascular reflexes. Now, are you still with me, Louise?
Yes, Prof. What you've described is a simple filtering system. Varying the in and out pressures regulates the amount of fluid filtered.
Absolutely. But hold on tight, because I'm going to take this puppy up a gear. At the confluence of the glomerular arterioles, a part of the endothelium has become highly specialised to form what are known as the juxtaglomerular cells. Now, these respond to a number of different stimuli, including direct innervation from the sympathetic nervous system. However, the feedback mechanism based on the nature of the filtrate entering the distal tubule is perhaps the most important. Within the distal convoluted tubule, the macula densa cells will respond to varying concentrations of solute within the filtrate. In turn, they will produce a variety of chemical mediators. These are likely to include prostaglandin and prostacyclin type molecules. Furthermore, this chemical crosstalk is also moderated by the intervening mesangial cells. The net result is the production of renin by the juxtaglomerular cells. Renin activates the renin-angiotensin system. Angiotensinogen is converted to angiotensin 1. Angiotensin-converting enzyme, or ACE, then converts this to the powerfully vasoactive substance angiotensin 2. Angiotensin 2 can alter the resistance in both the afferent and efferent limbs of the glomerulus. Which action predominates will depend very much on the circumstances and also the differing local nephron groups.
Let me just pause you there, Prof. I understand that the macula densa cells cross-talk with the juxtaglomerular cells, which, in turn, produce renin. Renin is part of the renin-angiotensin system, which results in the production of progressively more vasoactive compounds, and ultimately, angiotensin 2 controls the filtering system by tweaking the afferent and efferent arterioles.
That's correct, Louise. Well summarised.
But Professor, what is this about differing local nephron groups?
Well, this is the real key to understanding renal function. Listen carefully and all will become clear. What you need to appreciate, Louise, is that there are functional distinctions between regional nephron groups within the cortex. On closer inspection, we can identify peripheral, short-loop nephrons in the outer zones. These loops descend to the outer pyramidal regions of the medulla. They perform most of the day-to-day filtration operations, and their ability to concentrate urine is modest. The inner, or juxtamedullary nephrons, have long loops of Henle that dip deep into the medullary apical regions. These nephrons are distinguished for their ability to produce a markedly concentrated urine. The outer renal cortex receives a rich flow of well-oxygenated blood. In this region, an arterial flow rate of 5 litres per minute would be normal. The afferent arterioles will have an oxygen partial pressure of about 50 millimeters of mercury. These parameters are optimal for outer cortical nephron function. Within the inner cortical region, the flow rate drops to about 3 litres per minute. This is diminished further within the apical medullary zones. Here, flow rates are sluggish at about 0.2 of a litre per minute. Similarly, the partial pressure of oxygen may be as low as 15 millimeters of mercury. However, the juxtamedullary nephrons are well adapted to function in these more ischemic conditions. Indeed, they are the nephrons that the kidney turns to in times of stress. As a general rule, whenever the kidney is in trouble, she will usually respond by shunting blood to these inner zones. Am I still making sense, Louise?
Indeed, Prof. I can see how important these blood shunts are. But how are they controlled, and how may they vary?
Well, this blood shunting is mediated through two main mechanisms. First, there are the sympathetic nervous reflexes that innervate and act directly on the juxtaglomerular cells. Gradually, the process of glomerulo-tubular balance, as mediated through the juxtaglomerular apparatus, will fine-tune these shunts. The sympathetic reflexes act promptly at the time of acute obstruction. If this obstruction is bilateral, then afferent constriction in the outer cortical nephrons will reduce filtration and blood flow will be shunted inwards. For the juxtamedullary or deep nephrons, efferent constriction will predominate and glomerular filtration will be maintained. If the obstruction is unilateral, then these protective mechanisms will cause afferent arteriolar constriction at both levels and the kidney on that side will markedly reduce all function. As the clinical situation changes, the juxtaglomerular apparatus will constantly adjust regional blood flow as appropriate. It is this fine-tuning of afferent and efferent glomerular resistance that is central to understanding both intraregional shunting and how the kidney responds to obstructive pathology.
I can see now how important it is to understand this concept of regional shunting.
Great stuff, Louise. But let's both pause and see if we can take stock.
Yes, let me see if I can summarise what we have learnt so far. So, from the beginning. First, the Bowman's capsule receives an ultrafiltrate of plasma from the glomerular tuft. The proximal tubule then reabsorbs 80% of all salt and water and nearly all of the amino acids and glucose filtered. The loop of Henle creates a highly osmotic concentration gradient in the surrounding tissues. The collecting ducts pass through these zones of high salt concentration, which, given their very osmotic nature, facilitate the fine-tuning of water reabsorption. However, this reabsorption process does require the presence of the posterior pituitary hormone ADH, otherwise known as vasopressin. The collecting ducts are also responsible for controlling both potassium and acid-base balance. The distal convoluted tubule continues the process of salt and water reabsorption. In addition, this region is pivotal for controlling the mechanism of glomerulotubular balance. The highly specialised macular denser cells respond to changes in the concentration of passing solute. This information is relayed to the juxtaglomerular cells which, along with autonomic nervous inputs, auto-regulate the flow of blood through each nephron. Collectively, these structures make up the juxtaglomerular apparatus. It is this specialised association of cell types that controls glomerular filtration by regulating the arterial flow both into and out of the nephron. If afferent arteriolar constriction predominates, filtration will be reduced and blood shunts away from that nephron. If efferent constriction predominates, glomerular filtration is maintained. Throughout the kidney, there can be subtle differences in regional blood flow. At times, this will allow for the recruitment of specialist nephron groups and the protection of others. How this is executed will depend very much on differing physiological and clinical circumstances.
Well, that was a first-class summary, Louise, and provides us with an excellent overview of the basics of kidney function. We are now ready to move on to part 3 of this course, the more advanced aspects of renal physiology. At the tail end of your summary, you spoke of the auto-regulation of afferent and efferent arteriolar blood flow and how this is important to understanding blood shunting. We've also established that angiotensin II is central to this process. You reminded us that the macular denser cells signal changes in the concentration of passing solute. The juxtaglomerular cells respond by producing renin, which sparks the renin-angiotensin system. This is a cascade of enzymatic activity resulting in the production of angiotensin II. Angiotensin II also mediates a second important response, notably the production of a steroidal hormone, aldosterone, from the outer cortex of the adrenal gland. Aldosterone facilitates the reabsorption of salt and water from the collecting ducts. Sodium is reabsorbed at the expense of potassium and water is retained. This retention of water results in an increase in total body fluid volume and a rise in blood pressure. The expansion of total body fluid volume results in an increase in the venous return to the right side of the heart. In response to this, volume receptors in the right atrium produce a hormone known as atrial natriuretic peptide, or ANP. This tends to offset the physiological processes described so far. Notably, ANP seeks to offload body fluid volume and to reduce blood pressure. It achieves this in 3 main ways. First, ANP facilitates the loss of salt and water from the collecting ducts. In doing so, sodium is actively secreted into the collecting ducts in exchange for potassium. Therefore, plasma concentrations of potassium will rise. The second action is to inhibit the production of aldosterone from the adrenal cortex. And third, ANP will inhibit the production of renin from the juxtaglomerular cells. But in doing so, it also mediates its own unique action on the glomerular arteriole. Specifically, ANP stimulates afferent arteriolar dilatation along with efferent constriction. The net effect of this is to markedly increase the blood flow in the vasa recta. In doing so, the vasa recta tends to wash out solute from the medullary regions. This concept of medullary washout is important. Clearly, it will reduce the concentrating ability of the nephron. During the obstructive phase, not only is the urine production reduced, but the urine that is formed is usually of a weaker concentration. However, the washout of solute from the renal medulla is dramatically worsened with the relief of obstruction. I will be building on this idea in part 4 of the course. But for now, let us simply accept that the accumulation of ANP may be priming the kidney for a more significant washout that may follow. Indeed, to conclude the third part of this course, let us appreciate that, under normal physiological conditions, all of these adjustments are subtle. There are several interacting autoregulatory systems that work to normalise body fluid volume and blood pressure. However, in the context of bilateral renal obstruction, these consequences can become markedly more profound. Last night, Joe Bloggs suffered from one of the more severe consequences of renal tract obstruction. It is by understanding the physiological events that had taken place prior to his catheterization, and then, following the relief of his obstruction, that we might have been able to have made some predictions about the possible outcomes. In doing so, we could, perhaps, have minimised his risk. And that brings us on to part 4 of this course. A distal obstruction puts back pressure on the nephron. Both the collecting ducts and the thin ascending limb of the loop of Henle are particularly susceptible to the insult of distal obstruction. Predictably, damage to these structures can lead to the inability of the kidney to concentrate urine. So, the reduced volume of urine that is accumulating in the obstructed system will become diluted. Now, how relevant this degree of dilution is in clinical terms is very much one of degree. Put simply, the kidney is a concentrating organ, and so, normally, the urine is hypertonic relative to plasma. If the kidney is struggling to perform, then the concentrating ability may diminish and, at the barest minimum, it may break even with an isotonic urine. However, if the kidney is really in trouble, the urine she makes will be hypotonic to plasma. I pause, Louise, to stress that this distinction is of central importance to the story I tell. Following the relief of obstruction, the detection of a hypotonic urine usually indicates greater problems, but more of that in a moment. If we just dwell on these nephron regions that are particularly susceptible to the obstructive insult, then it should be clear that, in addition to the problem of producing a concentrated urine, certain electrolyte disturbances are also common. As we have established, the collecting ducts are the principal sites for potassium and hydrogen ion regulation. It is not unusual to detect a wide range of perturbations specific for these ions, and problems with acid-base balance may also follow. In the case of post-obstructive problems, hypokalemia is one of the more common presentations.
I'm getting the picture here, Prof. But let us have a short pause to summarise. Obstruction to the collecting system increases back pressure on the nephron. This is transmitted, first to the most distal part of the nephron and then to the most fragile part of this structure. Understandably, the collecting ducts and the loops of Henle are the regions that take the biggest hit. It follows that electrolyte disturbances are common, in particular, abrogations of potassium and hydrogen ion function. Damage to the loops diminishes the kidney's ability to create that zone of high solute concentration in the renal medulla. With collecting ducts that may well already be impaired, passing through this zone of reduced tissue tonicity, the result is, quite understandably, a reduction in the ability of the kidney to produce a concentrated urine.
That's correct, Louise. And when the obstruction is relieved, this is likely to get worse for a number of reasons. First, there is usually a sudden and dramatic restoration of blood flow to the kidney. Indeed, for a short period of time, the kidney may even become somewhat hyperemic. This huge gush of blood may further drive the washout of solute from the renal medulla.
So, the spectre of medullary washout that had begun with the accumulation of atrial natriuretic peptide is now compounded with a hyperemic restoration of blood flow. And given the possible impairment of the components of the nephron that are central to concentrating urine, any urine produced at this time will be dilute and watery.
That's correct, Louise. But still, the kidney needs to offload that excess body fluid volume. A diuresis of some sort is really inevitable. Now, you just remarked that there will also have been an accumulation of atrial natriuretic peptide. Of course, this is likely to drive further salt and water loss, as well as facilitating the medullary washout. In addition, there may also have been a build-up of osmotically active compounds, such as urea, which may further contribute an osmotic component to the diuresis. But Louise, realise that all this is essentially a normal physiological response. As long as the kidney is producing a urine that is more concentrated than plasma, then she is doing her job. The barest minimum that will be acceptable in health will be a urine that is isotonic with plasma. The problem comes if the tubular impairment leads to a can't cope situation. If this happens, then salt and water floods through the kidneys and the normal regulation of electrolytes fails. There may be problems with acid-base balance and untoward potassium shifts. By and large, although the loss of body salts is great, the relative loss of water is greater. That is why the urine is hypotonic relative to plasma. And that, Louise, is why a hypotonic urine is a sinister development.
So in essence, we have two distinct forms of post-obstructive diuresis. One that is physiological and unlikely to lead to problems, and one that is pathological and should cause us concern.
Yes, this latter situation is essentially one of a salt and water losing nephropathy and can lead to electrolyte and therefore cardiac problems.
But Prof, is there a simple way to distinguish between the two of them?
Indeed, Louise. They can in fact be distinguished by the definition. So, I will conclude this session by defining the two clinical subtypes of post-obstructed diuresis. In part 5 of the course, I will tighten this definition, as you will then see how this shapes my clinical management.
Prof, I have a feeling that a crucial number is stealthily gliding towards us from the deep. A number that identifies the sinister, and a number that is key to guiding clinical management. So, I feel that we should pay very close attention to the building of this definition.
Quite simply, the offloading of the excess fluid accumulation comprises a normal physiological diuresis, and the volumes of urine produced will vary in degree. In health, most kidneys can comfortably handle a loss of up to 200 ml per hour. By and large, losses of greater than 200 ml per hour that are sustained for more than a few hours tend to be more worrisome. So, I like to define a post-obstructive diuresis as being a urine output of more than 200 ml per hour over any 4-hour period. As long as the kidney can maintain a concentration of urine that is at least isotonic with plasma, then the diuresis remains physiological. However, if it can't and the urine becomes hypotonic relative to plasma, then the diuresis has become both salt and water losing and is pathological. Determining whether the urine is hypertonic, isotonic or hypotonic relative to plasma is really quite simple. The normal serum osmolality is about 300 milliosmoles per litre. Urine that is isotonic with plasma has a specific gravity of 1.01. Urine is normally concentrated to between 3 and 800 milliosmol per litre, which equates to a specific gravity of about 1.02. Very concentrated urine, say greater than 800 milliosmol per litre, has a specific gravity in excess of 1.03. Urine that is hypotonic relative to plasma has a specific gravity of less than 1.01.
So, Prof, the bottom line seems to be that 1.01 is a pivotal number, and one that we should remember.
That's correct, and that would be a good point at which to end this session. In part 5 of the course, I will be turning to patient management. You will see how we use this simple number to shape our clinical practice. When we return, I will be asking you how we can simply determine the specific gravity of urine.
Well, Prof, we can easily measure the concentration of the urine with a dipstick. Most urine lab sticks allow us to measure the specific gravity of urine.
Absolutely, and that is central to the management of a post-obstructive diuresis. If the specific gravity is less than 1.01, the urine is hypertonic to plasma. So, Louise, we can now be really clear on our clinical definition. Again, a post-obstructive diuresis is defined as a urine output of greater than 200 ml per hour sustained over any 4-hour period. If the kidney is concentrating the urine relative to plasma, it is a physiological diuresis and the specific gravity is greater than 1.01. If the kidney fails to concentrate urine, we have a pathological diuresis and the specific gravity is less than 1.01. Now, Louise, we also need to be mindful of the risk factors that might predispose our patient to the pathological state, notably anything that might contribute to tubular damage.
So, a prolonged acute obstruction will be of greater risk than one that is rapidly relieved.
Yes, and pre-existing renal problems or heart failure may also be relevant.
I guess coexisting infection must be of huge importance.
Indeed, and certain drugs can be of concern. You will recall how the chatter between the macular denser cells and the juxtaglomerular apparatus relies on prostaglandins. Well, if the patient has been taking a non-steroidal anti-inflammatory, then this can be problematic. Likewise, the renin-angiotensin response can be compromised by ACE inhibitors used to treat hypertension.
Well, clearly, Prof, all these potential problems can be rapidly identified at the time of presentation.
Absolutely. As soon as the catheter is placed, the volume of urine is measured and an empty drainage bag attached so that an accurate measure of the subsequent urine output can be recorded. The urine is dipstick tested to establish the baseline specific gravity and for the possibility of infection. We always send the urine for formal microscopy and culture, and if there is any likelihood of infection, a broad spectrum antibiotic is commenced. Blood tests are sent to establish both the electrolyte status and renal function. But most important, Louise, we must realise that our job is only half done. We now need to monitor our patient and check on the urine output every 4 hours. If the output is in excess of 200 ml per hour, we must monitor the specific gravity of the urine. At all times, the patient should be encouraged to eat and drink. Any potential fluid and electrolyte problems can best be offset by the normal ingestion of solute.
And of course, Prof, that is what food and drink is.
That's right. Whatever you do, don't starve your patient.
And if he does develop a significant post-obstructive diuresis?
Well, as long as he's concentrating his urine and the specific gravity remains 1.01 or above, just make sure that he is eating and drinking.
And if he has a significant diuresis and the specific gravity falls below 1.01?
Then he has a pathological salt and water-losing diuresis, and he will need to have intravenous fluids. One should begin with normal saline, although potassium may need to be added if subsequent blood electrolytes detect any evidence of hyperkalemia. I normally recommend that 80% of the previous hourly urinary loss is given back as intravenous fluid. But again, do make sure that he is eating and drinking normally.
And finally, Prof, at what point do we stop or tail back on our intravenous fluids?
That's easy, Louise. Once the specific gravity of the urine is 1.01 or greater, then you know that the kidneys are able to adequately concentrate again and you can stop chasing your tail. Joe Bloggs was an unfortunate but lucky man. Acute retention of urine is a common presentation of benign prostatic disease in older men. If we use our definition, we can determine that 50% of those men will display a post-obstructive diuresis. That is, 50% of men who require urgent catheterization to relieve their inability to void will produce a urine output of greater than 200 ml per hour, sustained over any 4-hour period. In 85% of those, the diuresis will be physiological. That is, the urine will be concentrated relative to plasma and the specific gravity will be greater than 1.01. In 15% of men, the diuresis will be pathological. The kidney will fail to concentrate urine and both salt and water will be lost. As water is lost in relatively greater amounts, the urine is hypotonic and the specific gravity is less than 1.01. Of this latter group, 3% will suffer with a clinical problem as a consequence of these fluid and electrolyte disturbances. Joe Bloggs was one such man. I do believe that he may have had several of the risk factors that may have contributed to his problem. From his history, it would seem that he had been going into retention for several days. He had had a prolonged acute obstruction, and one might infer that the back pressure on his kidneys was more than just an acute event. There was a significant time period during which damage to the susceptible nephron parts could have occurred. Furthermore, the fact that he was taking both non-steroidal anti-inflammatory medication as well as an ACE inhibitor could have blunted his recovery response. Finally, his case history does suggest that there may have been an associated urinary tract infection. So, it may be that his management could have been a little tighter. Post-obstructive diuresis is a phenomenon that we should always seek to identify. As you have seen, the management really is quite simple.
Indeed, Professor Muir, the take-home message is clear. Whenever an obstruction to the renal tract is relieved, there is a high likelihood that a diuresis will follow. If the urine output is greater than 200 ml per hour over any 4-hour period, then we should be wary of systemic problems. If the specific gravity of urine falls below 1.01, then intravenous fluid and electrolyte management is needed. The patient must also be encouraged to eat and drink normally. And you're right, that really is quite simple.